Picture this. It's 3 o'clock on a really busy Tuesday afternoon in the clinic.
Mm-hmm. We've all been there.
Right. You are already running maybe 15 minutes behind. The waiting room is backing up. And your next patient is sitting in exam room 3 in absolute agony.
Oh, yeah.
They have a red, hot, just exquisitely swollen first metatarsophlangeal joint. It is a classic, agonizing, textbook acute gout flare.
The kind where they can't even stand a bedsheet touching it.
Exactly. The patient is practically begging for relief, and your immediate instinct is to just reach for your prescription pad and order up a non-steroidal anti-inflammatory drug, an NSAID.
Which is completely logical.
It is. I mean, it's the absolute mainstay for shutting down this kind of intense, localized pain and inflammation. But as you glance at their chart, a glaring red flag pops up on the screen.
Let me guess. Cardiovascular history.
You got it. This patient is already taking daily low-dose aspirin for cardiovascular protection. Suddenly, that simple, straightforward prescription feels like stepping onto a pharmacologic landmine.
It really does. Because you're immediately faced with a barrage of questions. Should you avoid NSAIDs entirely? Should you try to meticulously modify the dose or the duration of the therapy? Or is it actually safe to just proceed with the standard full-strength therapy you would use for anyone else?
Right.
It is a highly unsettled question in the medical community. You're looking at a scenario that demands a really nuanced, highly individualized clinical approach, rather than just a knee-jerk reaction based on fear or habit.
Because the stakes are high.
Absolutely. You have a patient experiencing one of the most painful, acute inflammatory conditions we see in practice, and you are simultaneously staring down the barrel of a potential adverse bleeding event.
And I think most of us naturally lean toward prescribing the standard NSAID therapy anyway, at the usual dose and for the usual duration.
Yeah, that's the common default.
In the heat of the moment, that instinct feels incredibly justified. NSAIDs are incredibly effective at halting the inflammatory cascade of gout. And, the patient absolutely needs that low-dose aspirin to maintain their cardiovascular baseline.
You can't just take them off it.
Exactly. Plus, if you go digging through the literature looking for a massive, glaring neon sign of direct evidence, like a randomized controlled trial showing immediate catastrophic harm from combining them in this specific mild to moderate outpatient context, you aren't going to find it.
No, you really aren't.
So the instinct is to manage the acute pain aggressively and just assume the patient's baseline safety will hold.
What's fascinating here is why that default instinct, while completely understandable from a pain management perspective, begins to crack when you look at the underlying pharmacology.
Okay.
Yes, that definitive gold standard randomized controlled trial showing massive direct harm in this exact patient population is missing. However, what we're dealing with instead is a massive amount of biological plausibility.
The mechanism of action.
Exactly. We know intimately how these drugs interact at the receptor level.
Mm-hmm.
It is highly biologically plausible that combining an NSAI with aspirin significantly increases a patient's bleeding risk.
Right, because it's not just additive risk.
No, it's not just that they both independently cause bleeding. It is an active turf war happening inside the patient's body.
A turf war at the COX-1 receptor. Let's
Wow.
actually visualize that, because I think this is where the textbook pharmacology collides with the clinic floor.
Let's do it.
So aspirin works by irreversibly acetylating the COX-1 enzyme,
Mm-hmm.
which permanently disables the platelet for its entire lifespan. And that is what gives you that vital cardiovascular protection.
And knocks the platelet out completely.
Right. But when you introduce a reversible NSAID like ibuprofen for the gout, it physically occupies that exact same binding site.
It parks in the exact space the aspirin needs to get to.
Yes, it parks right there. So the aspirin gets blocked, it washes out of the system, and your patient loses their cardio protection.
Which is terrifying.
And then a few hours later, the ibuprofen unbinds and wears off. Suddenly you have a fully functional, uninhibited platelet right when the patient's cardiovascular system is vulnerable. All while you've simultaneously been stripping away the protective prostaglandins in the gastrointestinal mucosa.
That is the biological double hit we are so terrified of.
Yeah.
You are compounding the erosive effects on the gastric lining while simultaneously playing a really dangerous game of musical chairs with platelet aggregation.
It's a mess.
Because of that underlying undisputed biology, we simply cannot blindly apply standard full-dose NSAID therapy to everyone who walks through the door with a swollen toe. Relying purely on that default instinct without a second thought is a huge gamble with the patient's gastrointestinal and cardiovascular systems.
So it comes down to patient selection.
The paramount issue here is clinical judgment regarding the individual patient's baseline bleeding risk and their overall systemic tolerance.
Okay, let's unpack this. Because if the biology is actively screaming danger and detailing this catastrophic turf war at the receptor level, why do we even consider prescribing the NSAID?
It's a fair question.
If we know this interaction neutralizes cardioprotection and shreds the stomach lining, shouldn't the default be to just abandon the NSAID entirely? Isn't pushing forward a violation of the do no harm principle?
Actually, do no harm is exactly why the foundational clinical posture might actually surprise you.
How so?
Well, despite everything we just outlined about the biological plausibility for increased bleeding risk, the default should actually remain standard NSAID therapy at usual doses and durations.
Wait, you're telling me to look at the landmine, acknowledge the landmine, and then step on it anyway? How do you justify that clinically?
You justify it through a rigorous risk-benefit analysis based on the reality of the evidence we actually have versus the evidence we wish we had.
Okay.
It remains the default because this approach balances the necessary, incredibly effective symptom control of severely painful condition with what is, statistically speaking, generally a reasonable safety profile in the broader population.
But there's a catch, right?
There is. The caveat, and this is the crucial part that requires deep clinical honesty, is that our confidence in this standard approach is very low.
Low confidence in the default.
Yes. It is low precisely because we suffer from an absence of direct evidence proving the alternative is any better. We have zero proof that if we did modify the NSAID, say, by halving the dose or cutting the duration to just 2 days, that it actually improves bleeding outcomes for the patient.
So we don't have proof that modifying the therapy saves the patient from a GI bleed. But we do have absolute proof that lowering the dose will leave them sitting in their living room in excruciating pain.
Exactly. You are guaranteeing suffering for a theoretical safety net.
It comes down to competing hospitalizations. The ultimate clinical goal isn't just treating a risk score on a computer monitor. We want to keep them out of the hospital for a gastrointestinal bleed, absolutely. But we also have to keep them out of the hospital for untreated, complicated gout that spirals out of control.
Because the pain itself is systemic stress.
Severe pain drives up sympathetic tone, it spikes blood pressure, it increases heart rate. Ironically, leaving a gout flare undertreated because you are scared of an NSAID might trigger the exact cardiovascular event you're trying to prevent by keeping them on the aspirin.
You are walking a clinical tightrope. You have to treat the aggressive pathology, actively destroying the joint in front of you, without triggering a cascade of iatrogenic complications elsewhere in the body. You're balancing the immediate screaming demand for pain relief against a silent biological threat.
Which naturally leads to the biggest operational question for the practitioner holding the prescription pad. If the default is to cautiously proceed with the standard NSAID dose, when do we pull the ripcord?
Right. When do we deviate?
What are the specific red flags hiding in a patient's chart that should make us stop, abandon the default, and pivot our strategy?
This is where we shift away from population-level assumptions and dive into purely individualized medicine. The specific clinical triggers that warrant a deviation from standard therapy are very clearly defined, and they require you to look far beyond the swollen toe.
Give me the first one.
The first, and perhaps most critical, is the presence of multiple compounding bleeding risk factors. If you are looking at a patient who has a documented history of gastrointestinal bleeding, or they are of advanced age with frail mucosa, or they are concurrently using other blood thinners or anticoagulants, say a direct oral anticoagulant for atrial fibrillation on top of their aspirin, that is a hard trigger.
The theoretical risk just became real.
Exactly. The biological plausibility of a bleed has just transitioned into a high probability clinical reality.
The action there is clear. You modify the NSAID dose, shorten the duration drastically, or frankly, you abandon the NSAID entirely and choose alternative therapies. You pivot to systemic corticosteroids or colchicine, assuming those fit the patient's metabolic profile. What is the next red flag?
Organ impairment, specifically the kidneys and the liver. Significant renal or hepatic impairment dramatically increases the risk of NSAID toxicity overall, not just the bleeding risk.
Let's focus on the kidneys for a second.
Sure, NSAIDs block the prostaglandins that normally keep the afferent arteriole open. When you prescribe an NSAID, you are effectively clamping down blood flow to the glomerulus.
You're starving the kidney?
Yes. If your patient on low-dose aspirin also has compromised renal function, or they are on an ACE inhibitor that dilates the efferent arteriole, you are serving up a recipe for acute kidney injury. You simply cannot process the medication safely.
So what's the move?
The action here is to adjust the dose downward aggressively or avoid NSAIDs altogether.
Intolerance is another obvious trigger. If the patient has a documented history of severe dyspepsia, gastric ulcers, or an outright allergy to NSAIDs, the decision is made for you. You avoid them and find alternatives. But let's talk about the flare itself. Sometimes the pathology dictates the deviation, not just the patient's history.
Oh, absolutely. The severity of the gout flare is a major determining factor. If you are dealing with a severe, complicated, highly polyarticular gout flare, maybe it's in the toe, the knee, and the wrist simultaneously.
That sounds awful.
Standard outpatient NSAID regimens might not be potent enough to touch the inflammation anyway. That presentation requires highly individualized treatment. Often it means picking up the phone, getting specialist input from rheumatology, and likely moving toward combination therapy or biologic agents.
Let's run a hypothetical that happens in practice all the time. You do exactly what the guidelines suggest. You note a moderate risk factor. Maybe the patient is 68 years old on their aspirin, so you decide to play it safe. You modify the NSAID dose. You prescribe a half dose of naproxen for 3 days.
A very common approach.
But 48 hours later, the patient calls the clinic. They're still in agony. The toe is still pulsating. They cannot put a sock on, let alone walk. What do? The reality of clinical practice is that if you modify the dose to mitigate a theoretical bleeding risk, but the actual symptoms are inadequately controlled, you may need to revert right back to standard full dosing.
Yes. Assuming their baseline bleeding risk hasn't suddenly spiked, you cannot just leave them undertreated and suffering.
You have to escalate.
It highlights the dynamic nature of patient care. It is not a set-it-and-forget-it decision where you write the script and wash your hands of the problem. You are constantly reassessing the risk-benefit ratio in real time. If the low dose fails, the risk of untreated systemic inflammation and physiological stress now outweighs the theoretical risk of the gastrointestinal bleed.
Here's where it gets really interesting. We've talked about what should proactively guide your decision, but let's talk about the clinical pitfalls. Let's examine the traps that smart, well-intentioned clinicians fall into when trying to micromanage these complex, multi-morbid patients.
This is crucial. There are several critical do-nots that we have to establish to protect both the patient and the practitioner. These are the traps that often seem highly intuitive in the moment but are clinically flawed when you look at the data.
What's the biggest one?
First and foremost, do not assume that simply lowering the NSAID dose magically eliminates the bleeding risk.
But half the dose feels so much safer. It's the ultimate illusion of safety. You sleep better at night because you prescribed less milligrams, but the patient's physiology doesn't care about your feelings.
Exactly. The threshold for gastrointestinal toxicity is not perfectly linear. A half dose in a highly vulnerable patient with a history of GI bleeds is still a massive, unacceptable risk. You cannot use a lower dose as a behavioral crutch to avoid doing a thorough risk assessment.
You can't just cut the pill in half and call it a day.
Right. You must still evaluate the individual patient factors just as rigorously as if you were prescribing the maximum allowable dose.
Let's move to the second pitfall, which is a classic issue of evidence translation.
Do not overgeneralize evidence from broad general gout populations to this very specific subset of aspirin users. We see this constantly. A practitioner will read a fantastic trial about NSAID efficacy in gout and apply it universally.
But the populations don't match.
Right. The data for a healthy, robust 40-year-old with an isolated gout flare does not seamlessly apply to a 72-year-old patient who requires cardioprotective aspirin because they have 2 stents in their LED. You have to acknowledge the gaps in the literature. The healthy worker effect in clinical trials often excludes the exact multi-morbid patients sitting in your waiting room.
Which ties perfectly into the third pitfall. Do not ignore the patient-specific factors outside the joint. You are not just treating a localized crystal deposition in a toe, you are managing a complex systemic network.
Everything is connected.
Ignoring their cardiovascular comorbidities or their latest EGFR simply because you are hyper-focused on the joint pain is how adverse events happen.
Now let's address the temptation to just throw your hands up. The fourth pitfall is perhaps the most dangerous. Never avoid NSAIDs without providing a truly effective alternative therapy.
Avoiding NSAIDs entirely sounds brilliant in a textbook. It completely eliminates the bleeding risk. But when you have a patient whose toe feels like it's actively on fire, offering them an ice pack, a pat on the back, and a lecture about gastrointestinal safety is a great way to get a 1-star review, a very angry phone call, and a patient who ends up at the urgent care down the street anyway.
Undertreating the severe acute pain of a gout flare is a profound disservice to the patient. It causes unnecessary suffering, it prolongs the inflammatory state, and it destroys the therapeutic alliance.
It breaks trust.
It really does. If you decide the bleeding risk is simply too high to justify an NSAA, you must have a robust plan B ready to execute immediately. You need to be confident in prescribing weight-based colchicine or managing a steroid taper, and you need to understand the unique side effect profiles of those alternatives. You cannot just remove the primary tool without replacing it.
What about the severity of the data we use to make these decisions? I see practitioners cite scary statistics about NSAID bleeding all the time, but they're pulling from the wrong cohorts.
That is our fifth pitfall. Do not apply data from inpatient, severe, or refractory gout cases to your average everyday outpatient presenting with a mild to moderate flare.
It's an apples to oranges comparison.
Completely. The pathophysiology, the systemic stress, and the baseline risks of an admitted patient are entirely different from the person walking into your primary care clinic. Using inpatient morbidity data to scare yourself out of treating an outpatient is an error in scale.
I also see a lot of practitioners relying on really rigid, arbitrary numbers. They will look at a risk score calculator and say, well, their score is exactly a 3.5, so the protocol says I cannot use an NSAID.
Which brings us to the next clinical trap. Do not rely on unvalidated numeric thresholds for bleeding risk when making this highly specific decision. There is no magic number that suddenly turns a safe prescription into a dangerous one.
It's a spectrum.
Right. Clinical gestalt, comprehensive history taking, and understanding the nuances of the patient's daily life are far more valuable here than an arbitrary cutoff generated by an algorithm that wasn't designed for this specific drug interaction.
And the final pitfall.
The most encompassing rule of all: do not withhold effective symptom control solely because direct gold standard evidence of safety is absent. In medicine, we often have to act in the dark. We have to act in the absence of perfect data. Waiting for a flawless 10-year randomized controlled trial to tell you exactly what to do means leaving the patient in front of you in pain today.
So what does this all mean? We are operating in this massive, frustrating gray area. The evidence is either weak, conflicting, or just entirely absent for this highly specific intersection of gout, NSAIDs, and low-dose aspirin. How does a clinician synthesize this mountain of pharmacology, risk assessment, and biological plausibility into a daily functional operating procedure?
You synthesize it by focusing intently on what we know for sure and being ruthlessly honest about what we do not.
Okay, let's break that down.
We are highly confident that NSAIDs work effectively to reduce gout symptoms. We know that with absolute certainty. We also know that the bleeding risk from combining NSAIDs with low-dose aspirin is biologically plausible, even if it is not perfectly quantified in the literature for this exact population.
All right, we see the mechanism.
But what we absolutely cannot say definitively is that modifying the NSAA therapy guarantees a reduction in bleeding risk. Nor can we confidently say that standard therapy is inherently unsafe in every single aspirin user.
We are managing probabilities, not certainties.
So the safest, most logical approach is this: default to standard NSAA therapy. As you write, the prescription assess the patient's individual risk factors meticulously, scrutinize their renal function, probe their history for GI issues, account for their age and other medications.
Do the legwork.
Exactly. Only modify the therapy if those specific individual risk factors are elevated, or if adverse effects begin to manifest during treatment. And above all else, monitor the patient closely. Follow up with a phone call in 48 hours. Make sure the pain is actually subsiding and no signs of gastrointestinal distress are developing.
Which brings us to the ultimate, definitive one-line takeaway for the clinician listening right now. If you are going to write one thing down on a sticky note and slap it on the bezel of your computer monitor to guide you through your next shift, it should be this.
Here we go.
For acute gout flares in patients on low-dose aspirin, use standard NSAID therapy unless individual bleeding risk factors or intolerance justify dose or duration modification or alternative treatment.
That is the gold standard approach.
I am going to repeat that because it is the entire crux of the decision tree. Use standard NSAID therapy unless individual bleeding risk factors or intolerance justify dose or duration modification or alternative treatment.
It perfectly encapsulates the required balance. It gives the practitioner permission to treat the pain effectively and aggressively while simultaneously mandating that they remain hypervigilant about the patient's unique vulnerabilities.
Managing these patients requires stepping back, taking a breath, and looking at the entire board. You are treating the complex systemic health profile of the human being sitting on the exam table, not just the isolated crystal inflammation in their joint. You have to weigh the absolute necessity of their cardiovascular protection against the immediate screaming demand for pain relief, all while navigating the silent biological threat of gastrointestinal bleeding.
If we connect this to the bigger picture of clinical practice, it is a perfect reminder that critical thinking and comprehensive individualized patient assessment will always trump blanket one-size-fits-all rules, especially when the clinical evidence exists in a gray area.
We have to trust our training.
Exactly. We cannot outsource our clinical judgment to a generalized guideline when the patient in front of us presents with a highly specific overlapping set of conditions. This raises an important question about how adaptable our clinical frameworks really are. As the baseline medication lists of our patients change our risk assessment, algorithms have to evolve right alongside them.
Which leads me to a final, slightly provocative thought for you to mull over as you wrap up your charting today. We know that cardiovascular guidelines are not static, they are constantly evolving. Right now, we are actually seeing a major systemic shift in the medical community regarding the default prescribing of daily low-dose aspirin itself.
Oh yeah, it's changing rapidly.
It is no longer handed out as freely for primary prevention as it was a decade ago. As that trend continues and the criteria for aspirin use strictens, how might the baseline risk profiles of our gout populations fundamentally change over the next 10 years?
It's a fascinating shift.
Are we preparing for a future where this specific clinical dilemma, the NSAID versus aspirin catch-22, begins to fade entirely, only to be replaced by new, highly complex medication interactions as novel cardiovascular and metabolic drugs hit the market? The landscape of baseline patient risk is shifting beneath our feet, and the standard patient of today will not be the standard patient of tomorrow.
You have to stay on your toes.
Something to keep in mind the next time you open a chart and see a complex medication list. Keep trusting your clinical judgment, keep weighing those individual risk factors, and above all, keep questioning the assumptions that drive your daily prescribing habits. Have a great week in the clinic, and we will talk to you next time.